So we proceed with our next presentation, that is Dr. Alberto Felleti. He's joined us today. He's from the Modena University Hospital, Italy. He will be talking about the navigation of the cerebral aqueduct and the fourth ventricle. Dr. Alberto, could you please screen share and start your presentation? Can you hear us well? Yeah.
Yes, I can hear you.
Okay.
Let's see.
Yes, you're well connected. Yep.
Yeah, good. So, okay, can you see my presentation?
Yes. Yeah, we can see that.
Okay.
Yes.
Okay, very good. So, good morning to everyone. My name is Alberto Felleti. I am a neurosurgeon working in Italy, in Modena, which is a city in north part of Italy. I have been a fellow with Professor Yoko Kato 2 years ago. So I will talk to you today about the navigation of the cerebral aqueduct and fourth ventricle with a flexible endoscope. As you all know, in the past, ancient Greeks thought that the world was flat, and they also thought that the western limit, the western border of world, was constituted by the Pillars of Hercules, which is a place that nowadays we know as the Strait of Gibraltar between Spain and Morocco. So it was forbidden for human beings to move over that limit because it was considered dangerous and nothing could be found besides water. And for many years, the cerebral aqueduct has been considered like the Pillars of Hercules for neurosurgeons and for neuroendoscopists. Even after the introduction of the flexible scope. So only the adytum of the aqueduct could be seen, as you can see from these two pictures. But in the recent years, we and other groups showed that it is actually possible to navigate the cerebral aqueduct with a flexible endoscope. And it is possible if you are, of course, if you have a good expertise in handling an endoscope, and if the cerebral aqueduct is not stenotic, of course. It is possible in a safe way. This is a short video showing you the navigation now of the third ventricle. This is the abenular commissure, posterior commissure, the adytum of the cerebral aqueduct that we are actually passing now. Now we are navigating through the aqueduct, and finally we enter the fourth ventricle, and we can see the choroidal plexus of the fourth ventricle, cerebellum, here, and the Magendie foramen. So this is possible with a flexible scope. What can be done with flexible scope? Many things, actually. Of course, third ventriculostomies and biopsies, but I will not talk about that to you today because it's possible to do these procedures also with rigid scopes. I don't know if my presentation moves on. Okay, so I will skip this part because it's possible to do that only also with a rigid scope. What else can be done? In some selected cases, we can aspirate, like in this case that we published, we can use the working channel of the flexible scope as a sucker, and we can remove the tumor, if the tumor, of course, is small, not more than 2 centimeters and soft. And we can remove these tumors from the posterior part of the third ventricle and also from the aqueduct. What else? We can manage arachnoid cysts. Look at this case. This patient had a huge cisterna already in the fourth ventricle. We are sliding our endoscope in between the roof of the fourth ventricle and the floor of ventricle. This is the brain stem, of course. See how narrow it is because of the compression of the cyst. And then finally, we see the canalis centralis medullaris there and pike, and then the wall of the cyst, which is here. We always check very carefully the wall of the cyst to see if it is transparent, because it's important to try to understand what's behind the wall before making the first hole, which is this. Okay, we made the first hole in the wall of the cyst. Then usually we try to enlarge this hole with a balloon, or sometimes we try to shrink the wall of the cyst using monopolar coagulation. This is the final view with the Magendie foramen cisterna magna, which is free now. And we are withdrawing the endoscope. You can see how much larger the fourth ventricle is after the fenestration. It gained a normal anatomy again. Then, of course, we performed also a third ventriculostomy in this patient. Also, aqueductoplasty can be performed with flexible scope. When I talk about aqueductoplasty, I'm not saying I am
Okay, I think we have a little freezing of the Wi-Fi. Can you hear me, anybody?
I can hear you, Dr. John.
Okay, yeah, we're having a freezing there of the, presentation. Are you there, Hira?
Oh, can you?
Yeah, okay.
Can you hear me?
Yeah, go ahead, Alberto. Continue.
Okay, I don't know what part you missed. I was talking about aqueductal stenosis. We treat with transaqueductal navigation only those stenosis that are due to membranes. Like in this case,
Dr. Alberto, sorry to disturb you. Actually, your slides are not shown. They are not shared.
Oh, wait, let me check.
Yeah, you're not sharing it.
What's the problem?
Yeah, thank you for bringing that up, Disha.
Wait. Let me see if I can share again.
Yeah, there you go.
Yeah, sorry. I'm in China right now, and the connection is really bad.
It's okay. We're getting through.
So
we can see it now.
Okay, let's see if I can make it work. Can you see it?
Yes, we can.
Okay. Okay. So you can see. Okay.
Yes.
So here in this video, I did you can? Okay. In this video, I did a perforation of a thin membrane, which was the cerebral aqueduct. Of course, I used a balloon fenestration, and then you can actually navigate the fourth ventricle. In this case, we know
I guess we have another delay by the Wi-Fi connection of Alberto. I believe he's in Russia now. Go ahead, Hera.
Yeah, there was a problem with his connection because of this firewall thing. So I think he's having trouble with the internet connection at the moment.
Okay.
I think we just wait for a while until he gets back.
Okay.
Yeah. Okay.
It came through the last time. This is the unfortunate part of Wi-Fi. It's inconsistent. We never know if it's going to work. So Alberto's in Russia now. Or China now. He's in China. Can you hear me, Alberto? Can you hear me?
Yeah, I can hear you.
Okay, you dropped off. You dropped off there at the end of your presentation. You want to finish it off?
Oh, okay. Can you see my presentation right now?
Now I can. Okay, you got a screen share.
Okay. So I was saying that in this case, it was very dangerous to perform a third ventriculostomy because the brainstem was pushed against the clivus, and also the basilar artery was obstructing our view.
Dr. Alberto, sorry to interrupt you. Again, the slides are not. The slides, we are not seeing the slides. It's not shared.
Oh my God, wait. Let me check again. Let's try again.
There we go.
Okay, you can see them now?
We can. Yes, we can.
Okay, in this case, we considered third ventriculostomy to be pretty dangerous. So we navigated through the cerebral aqueduct and we noticed the obstruction of the Magendie foramen, and we did a Magendie-plasty, and the outcome of the patient was very well. But I think the most interesting application of flexible scope is the aspiration of intraventricular blood hemorrhage. As you know, intraventricular hemorrhage is a very challenging disease with a very high mortality rate. The standard treatment is external ventricular drainage. Of course, it's a very simple procedure, and it allows a fast resolution of acute hydrocephalus, but it must very often be bilateral. It frequently obstructs, and you have to wait a long time before the blood is washed out. So the stay at the hospital is very long, and you can have many complications. We showed that removing intraventricular clots with a flexible scope decreases mortality and decreases VP shunt dependency in these patients. So just some examples. See, this is a preoperative scan of this patient with intraventricular hemorrhage, and after endoscopic treatment, we can obtain a complete resolution of this intraventricular hemorrhage. Notice the fourth ventricle, which is completely free of blood in this case. This is possible only with flexible scopes, using the operative channel of the scope as a sucker, and with a very simple instrumentation like a syringe to do aspiration, and of course ringer lactate for irrigation. The access is a frontal precoronal bar hole, which must not be too lateral. Otherwise, it's difficult to introduce your endoscope in the cerebral aqueduct. Just two maneuvers are important for this surgery: irrigation to make the field more clear, and aspiration to remove the clots, of course. Initially, this kind of surgery can be very frustrating because you can see only red when you enter the ventricles. Of course, you see only blood, but finally some landmarks appear, like this, in this case, the choroid plexus, and you have to follow the choroid plexus until you see the Monroe foramen, and then you keep doing aspirations and irrigations until you set the third ventricle completely free of blood, like in this case here, the optic chiasm. Then you direct the endoscope to the posterior part of the third ventricle, and then you keep doing aspirations and irrigations, and finally you will see here the aqueduct, the adytum of the cerebral aqueduct, posterior commissure, abenular commissure. You can even see the roof of the third ventricle, and then of course you have to enter the cerebral aqueduct and aspirate the blood from the fourth ventricle. And finally, after the aspiration, the complete aspiration of the blood, you will be able to see the Luschka foramen with its choroid plexus, and also the Magendie foramen. In some cases, we perform coiling and neuroendoscopy in a very short time. So you can obtain, you can secure the aneurysm, of course, with coiling, and you can obtain the resolution of intraventricular hemorrhage in a very short time. Look at this case, basilar artery aneurysm. It was coiled, and then after neuroendoscopy, see the blood is completely disappeared from the ventricles, even from the fourth ventricle. In very selected cases, we can navigate the cerebral aqueduct from the fourth ventricle. In this case, we operated this patient with a tumor in the posterior fossa in a prone position with a microsurgical technique. It was a very bleedy tumor. So at the end of the surgery, we wanted to inspect the ventricular system with a flexible scope. So now we are in the fourth ventricle, and we are entering the cerebral aqueduct from the fourth ventricle. This is a very unusual view. This is the aqueduct. And in a few seconds, we are going to see the third ventricle. This is the posterior commissure, and this is the additum of the cerebral aqueduct. We entered the third ventricle, and actually we have seen a blood clot. Of course, in the prone position, blood for gravity can enter the cerebral aqueduct and the third ventricle, and it's a potential danger, because these clots after surgery can obstruct the cerebral aqueduct and give acute hydrocephalus. So we aspirated these blood clots from the third ventricle. You can arrive until the Monro foramen, like you can see in this case. We aspirated blood from the Monro foramen. And with the same technique I showed you before, aspirations and irrigations, we finally obtain the complete release of blood from the third ventricle with a very unusual anatomy. Here you can see the two foramina, the anterior commissure and the infundibulum. Here, this is the optic chiasm. Okay, and just to conclude, if we use fluorescing sodium, intravenously injected fluorescing sodium, and a special filter for the camera of the scope, we are able to see what is otherwise impossible to see inside the ventricles. The first anatomical structure that we can see with this technique is the subependymal vascular network. Here you can see the choroid plexus, which become fluorescent. And here, I don't know if it is possible for you to see this tiny vascular subependymal network, which is impossible to see with normal light. But probably, and I will finish with this slide, the most interesting application of fluorescence is to detect the presence of the circumventricular organs, which are very strange structures that cannot be seen with normal lights. Here, this is the tuber cinereum. With fluorescence, you can see area postrema. You can see the median eminence and also the organum vasculosum lamina terminalis. This is lamina terminalis. Again, tuber cinereum and median eminence appearing with fluorescence. And beyond the pillars of Hercules, actually, so in the fourth ventricle, we can also see a circumventricular organ, which is located in the inferior triangle of the fourth ventricle. Here we are entering the fourth ventricle, choroid plexus of the fourth ventricle. And now with fluorescent mode, you can see these two leaves. This is the area postrema of the fourth ventricle, which is not possible to see with normal light. This is the canalis centralis medullaris. Okay, thank you very much. And sorry for the technical problems.
That's okay. That was a nice presentation, Dr. Alberto. We are glad you made in time.
Thank you.
Yeah. Any questions, any comments from the panelists for Dr. Alberto?
Dr. Alberto?
Yes, Dr. Divya.
Yeah, it was very impressive. And seeing the circumventricular organs, like, yeah, it was very good. So one thing I want to know from you, like you remove the intraventricular hemorrhage through the endoscope using the flexible endoscope, and means what is the outcome? Like, does it reduce the means what is the better outcome you saw? Like removal of the blood clot without removing and with removing. Is there any difference in the occurrence of hydrocephalus or?
Yeah.
What what difference it makes? Like, just want to know.
We performed a comparison between patients treated with endoscopy and patients treated just with external ventricular drainage. And we noticed that the length of stay in ICU was shorter for patients treated with endoscopy. We also noticed that the outcome was better. We used the Glasgow Outcome Scale to perform this analysis. And we also noticed a decrease in VP shunt dependency in patients treated with neuroendoscopy. Of course, there is a bias in our comparison because we compared patients which were treated with ETV years ago, because after the introduction of the flexible scope, we always use flexible scope for intraventricular hemorrhage. So there is a time shift between one group of patients and the other group of patients. But there are evidences in literature that endoscopy can actually improve the outcome of these patients.
Okay, and means once you go in, like, did you encounter any complication, because everything is red? Like any complication which you encountered with the endoscope?
Yeah, of course, the major possible complication is intraoperative bleeding. But in my experience, and not only in my experience, also in the experience of my former mentor, who taught me how to use the flexible scope, if you encounter a bleeding in the ventricle, you don't have to panic. You just need to keep doing irrigation. So irrigate, irrigate, and wait, irrigate and wait. I was always able to stop the bleeding just with irrigation.
Okay, fine. And like, how do you change the direction of the flexible scope? Like,
okay, good question. The flexible scope has like a handle you can use to move the tip this way, up and down. So for up and down movements, you can use this tool, which is controllable with your hand. But also you can use the other hand to slightly rotate the endoscope, so you can change this direction. Okay, rotational direction.
Okay, thank you so much, Dr. Alberto.
Sure, thank you.
Thank you so much, Dr. Divya. Any other question, any comments from anyone else?
Dr. Alberto, thank you for presentation. It's amazing, it's cool. And I have a question. Can we use this flexible endoscope for transnasal operations? Transnasal, transvenous?
Well, I think you can, but I don't think it would be the best tool. I do transnasal, transphenoidal surgery with rigid scope. Rigid scope it has a much better view. Probably you noticed from my videos that the vision is not very clear like a rigid endoscope, because this endoscope is made with fibers, fiber optics. However, I think 1 year, 1.5 years ago, both Olympus and Storz introduced a new flexible endoscope with a chip on the tip. So now the vision is like a microscope. However, I really think that you need a flexible scope if you have to deal with a complex geometrical anatomy like the ventricular system. But if you have a very straight way, like for transsphenoidal surgery, I don't think there is any need to change from rigid scope to flexible scope, even because the flexible scope has a smaller working canal. So I think maybe you can use flexible scope at the end of transsphenoidal surgery if you want to inspect some hidden corners of the surgical field. But I would not suggest to move from rigid to flexible scope for transsphenoidal surgery.